Good morning, everyone. My name is Aurelie, the Massachusetts Care Transition Lead from the New England QIN-QIO. Thank you for joining us for today's webinar, Charting the Course, Addressing the Needs of Super Utilizers at Lawrence General Hospital. We're coming to you live from Lawrence General, and they are building a new surgical center nearby, and we apologize in advance if you hear any background construction noise. So before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. The recorded presentation will be available on our website within a few business days. The slide deck is currently already posted on our website. The phone lines will be on mute for the duration of the presentation. However, we will have a question and answer time at the end of the presentation, and we'll instruct you at that time how you can ask questions. These are our learning objectives for the day, and what we really want you to walk away with today is understanding data elements and operational processes. We want you to think about establishing the right community partners for your population, and also thinking about improvement processes. During virtual learning sessions, it is so important for us to connect with each other. So please use our chat feature, which is direct on your screen, to introduce yourself. Let us know how you use data or would like to use data to better understand your patients. Lynn Chase, our New England Regional Lead for Care Transitions, will be responding to comments, weighing in, and sharing highlights at the end of the session when we open up the lines for discussion. So moving on to the content of this great program, I have the pleasure of introducing Aurelie Cordier from the Health Policy Commission. Aurelie provides day-to-day operational leadership and overall coordination of the care delivery, investment, and innovation team, as well as related analytic tasks examining health system performance. She utilizes performance improvement tools to streamline processes and develops activities related to quality initiatives to ensure continuous quality improvement and integrate QI/PI activities into agency culture. I will hand it over to Aurelie.
Thank you, Cheryl. It's a pleasure to be here today, and I would like to walk you through a little bit of a story about the Health Policy Commission, as well as making you aware of what CHART is in two phases. So telling you the story of the Health Policy Commission and CHART is also telling you the story of healthcare policy throughout history, from an evolution from insurance to healthcare reform, calling your attention to really two critical historical milestones in terms of healthcare reform. The first one passed through Chapter 58 in 2006, and the recent one, which really is the birth of the Health Policy Commission, as well as its sister organization, TIA, as the Center for Health Information and Analysis in 2012. This was actually signed by our governor on November 5, 2012. Some critical elements there to note is the individual mandates, as well as a very strong focus on cost containment, which is why we are also here today to talk about CHART. When we're looking at the mission and who we are at the HPC, we are an 11-member board appointed by our governor, our state auditor, as well as our attorney general. We are led by our chief chairman, Dr. Stuart Altman, as well as our executive director, David Sells. There are really four pillars to our activities within the HPC, and one of them is really looking at certification models and programs, so you might be familiar with the patient-centered medical home, as well as accountable care organization. CHART is the second one, and we'll go into detail. It's defined as a community hospital to establish the foundation of necessary sustainable system transformation. We're also looking at the cost trends, very recently looking at the driver for healthcare, as well as market performance to define the four activities. Looking closely at CHART, CHART is defined as our community hospital acceleration and revitalization transformation program, This was started at a $120 million investment as a one-time assessment, with the goal being to improve the value of healthcare system while containing all healthcare costs. There were two phases to the program. One, and we'll go into phase 1 and phase 2, about $9 million for phase 1 and $60 million for phase 2. The rest really being covering the smaller investment program within the Health Policy Commission, also some technical assistance, engagement, evaluation program, and administration costs. The eligibility criteria to participate in CHART were really defined by the legislature, and the three criteria was that the organization had to be nonprofit, non-teaching, and low price when it comes to the negotiated price to the commercial payers. When we're actually looking at the goal of CHART, we're really looking at promoting care coordination, integration, and care delivery transformation, as well as advancing electronic health record adoption and information exchange across among the different providers. But the umbrella of CHART is really to get organizations ready for an accountable care organization model. So when we're looking at phase 1, this was about a $10 million opportunity focused on the transformation, and it was just a 6-month period. There were 27 hospitals involved, and all of them pretty much engaged in a very variety of initiatives around the rapid cycle pilot program, capabilities or capacity development, and such as lean initiatives. And you'll see also enhancement of access to behavioral health services, which will also resonate as we go into phase 2. Some reduction of lengths of stay and readmissions were also part of those initiatives. When invited by Lawrence General today, the Lawrence General phase was really a planning initiative to really develop a detailed business and operational blueprint around care management. This was a way to bring the focus and the prioritization of the overall strategic approach, landing into what will be phase 2 in where we are today. When we're looking at phase 2, we also need to learn the lessons from phase 1. And our takeaways were that really as a foundation system for phase 2, we really need to understand the composition of transformation teams and how critical they are to the success of a program. Important to note the multidisciplinary team across all the hospitals. Also a very strong focus on process improvement in operationalizing like different ways of efficiency and measuring outcomes. And finally, that the leadership as well as project manager has to be involved from the inception all the way to the improvement process of the program. What will lend itself very clearly into phase 2 is that data analysis is absolutely essential to measure the performance and drive that improvement throughout the program. We are now into phase 2. Phase 2 has 28 awards, $60 million investment, and a 24-month period. The overall the goal of phase 2 is really around 3 primary aims: to really maximize hospital utilization as a whole, including ED utilization, but also to improve access to behavioral health services and improving hospital processes by reducing waste and improving quality and safety throughout. There were different phases to phase 2, from the inception of an RFP to submission and review to the award recommendation, and a very lengthy implementation planning that I will let the Lawrence General team weigh in on the impact that it has in the ongoing work. When I'm looking at CHART phase 2 today, I see a lot of synergy between the different programs, and I think actually bucket them in 4 different categories. A lot of the hospitals are focused on high utilizers. Some are looking at a very specific population focused around social complexity or medical complexity, as well as behavioral health services. And then the goals also of each of the hospital, as they are geared towards the primary aims of CHART, is really to reduce 30-day readmission with a range of 15 to 20% reduction based on the target population, And we also have about 10 awards that really focus on reducing ED revisit utilization as well as length of stay. To date, as of today, all the programs have actually launched their initiatives, and the common denominator for all of them is very much around like the data support that they will need, and most of them, if not all of them, have to report monthly on the standard cohort-wide as well as some very tailored program-specific measures. The reporting is really to inform coaching as well as technical assistance. And it's important to note that one key element of the chart is that all hospitals are now accountable for achieving their measurable aid statement, whether they bucketed a certain percentage for their readmission or their AD revisit. The example that I would get is that chart phase 2 for the Lawrence General team is really to reduce those readmission and ED revisits for patients with medically and or social complex needs throughout the work of social workers and nurse case management based transitional care units, as well as a linkage to the elder services and a very strong focus on leveraging technology. So we are very excited with their initiatives, and I will hand it over to the team to go into more detail.
Thank you very much, Aurelie. That was a great overview of the Health Policy Commission. It also gets me excited, though, to hear more as Chart Phase 2 is implemented across the state. I really appreciate that introduction. Next, I'm going to turn it over to the Lawrence General Hospital team. From Lawrence General, we have Robin Hines. She's the Senior Director of Care Integration and Transformation. At Lawrence General, Robin is instrumental in applying significant emphasis on high-level strategies that counter new trends in payment structure that are crucial to moving from a volume-based reimbursement environment to value-based. We also have Nicole Garabedian, Manager of Integrated Care. Nicole has over 8 years of healthcare experience with extensive knowledge of care management, utilization management, discharge planning, and transitional care. And we also have Theresa Sievers. She's the Vice President of Quality and Patient Safety. As part of her responsibilities at Lawrence General, Theresa oversees the measurement of quality and patient safety outcomes for the Delivery System Transformation Initiative Waiver and the Chart Investment Program project. Thank you all so much for joining us, and I'll ask Robin to get us started.
Thanks, Cheryl. So I'm just going to go a little bit into the objectives of what we're going to talk today about. I'm going to give you some history of our hospital, our community partners, and where our vision of cross-continuum care management plan came from. Terry's going to go into a little bit more on our aim statement and then talk about our population through data analytics and how we use that to determine our measure of success. And then Nicole will talk a little bit more about how we operationalize our program and how we've used PDSA cycles to do and look at rapid cycle improvement. And then she's going to go over a case study at the end of a really interesting case that I think we've had some significant impact to see where we really have put a lot of the work that we've done and how it really impacts at the patient level. So I just want to give you a little description of our hospital. Some of you in Massachusetts know us, others do not. So we are a 189-bed, 41-bassinet private nonprofit community hospital. So we provide care to Massachusetts residents in the Merrimack Valley and also in southern New Hampshire. We have been a community hospital for nearly 140 years. We're also clinically affiliated with Beth Israel Deaconess Medical Center, which is a tertiary care hospital and floating hospital for children at Tufts Medical Center. We typically have about 13,000 discharges a year for our inpatient population and about 2,600 patients for our observations annually. We're also a disproportionate shared hospital. We have the second highest rate of low-income inpatient admissions within the state. And what a DISH hospital means is that we have a high degree of government payer mix, around 70%. 36% of that is Medicaid-based. And as many of you know, Medicaid typically pays 60 cents on the dollar for every service rendered in the fee-for-service world. So with that specific DISH hospital status, we've been eligible for certain Section 1115 areas of the Affordable Care Act through a delivery systems transformation initiative to look at care delivery in a different way and move from a volume-based perspective to value-based. We are one of 6 facilities in the state involved in this. Our first waiver lasted around 3 years, and now we're embarking on an additional 3-year waiver. And the expectations of that waiver is really to ready hospitals for alternative payments in the future. But much of that work within that waiver has been done in the arena of care transitions and improvement in readmission reduction, and that really helped us prepare for the CHART initiative. So I just wanted to go a little bit about our population statistics within the area of Lawrence, Massachusetts. As you can see, these stats really speak for themselves in terms of comparing this region to the entire state. Many families live in poverty. They rely very solely on public transportation, so traveling into Boston for major surgery and specialty care is a significant burden for them. That's why it's very imperative that, we are able to provide care at the local community-based nonprofit area. We have a large Latino population as compared to Caucasian. Many of our patients speak Spanish. We have a large foreign-born population that typically can be undocumented, so that creates barriers sometimes within itself. Our poverty level is quite below baseline from the state, and as you can see, our median income is quite low as well, and our crime rate is quite high. So, many of the work that we have done through the hospital really targets programs to residents with really the highest behavioral risk factors. We have a large obesity risk factor here. We have a lot of patients with heart disease, stroke, cancer, diabetes, smoking, and those tend to be really high readmission patients that really need a lot of social and medical support within this community. So I also wanted to describe the fact that our CEO really sees us as a regional health system. That's really her vision, to really create us from this community hospital to a regional health center. Not only do we service the Lawrence area, but we do service some other affluent communities around here. Some of you from Massachusetts know Andover, Haverhill, Methuen, and then parts of southern New Hampshire. So it's a different mix of populations throughout. We really have had to look at creating a low-cost, high-value system here and really support all our integrated physicians. We have a large physician hospital organization. One of the things that is different about us is we don't own our own physicians within this hospital, so we really have to partner with a number of different organizations, such as Nantucket Medical in this area, the Greater Lawrence Family Health Center, which is a local patient-centered medical home, and then many of our independent surgical and medical specialists make up physicians that are part of the Bethesda Deaconess Care Organization. So that really represents our physicians and our primary care. So really, the work that we've done by sort of creating a virtual regional health system has really put us, making us well underway into getting to that vision of what our CEO, Diane Anderson, sees us as. So I did want to give you a little bit of a perspective of what our vision is with CHART. As Aurelie described, we did have an opportunity to look at, from a planning grant through CHART, the first ability in this process was to see where we had some gaps. Our focus is guided by the triple aim, better health, better experience, lower costs, and so keeping care local is our strongest aim, and we really live up to these principles. Population health is one of our main strategic visions to be able to deliver this low-cost, high-quality health care. And that really combines the necessary elements of quality, care management, health IT, and really in order to really achieve true population health. And so as you can see, our vision for the CHART grant really looked at where there were gaps that existed in achieving that triple aim. And through earlier work, we had really centered on building the inpatient infrastructure and then building the outpatient infrastructure to support patients, but then there really was a gap between the transition period. And that was where we saw an opportunity to use care management resources and build a support system for patients during that time of transition. And Nicole will describe a little bit more about how we operationalize that. So our journey began probably in 2010 with our STAR program, and I'm not sure if everybody is familiar what the STAR program is, but it's the State Action on Avoidable Rehospitalization. And that was sort of a pilot project where 3 states, Massachusetts, Washington, and Michigan, had really looked at ways to put interventions into place to try to get a hold of readmissions and what the state of the union of readmissions really look like, because as we know, healthcare costs are continuing to be on the rise. And so that really kind of catapulted us into a lot of the work that we did that I described with our DISC waiver that really focused on care transition. So in 2012, through that DISC waiver, we worked very closely with the patient-centered medical home, Greater Lawrence Family Health Center, and really worked to manage high-risk diagnoses, including CHF, COPD, and diabetes. And we were very successful in this, where we did at one point see a lower diabetic readmission rate of 54% and a lower CHF readmission rate of 34%. So we knew that with targeted interventions, we really could put, putting forth that work, we really could make a change. And so then when the chart phase 1 came, we saw that this was, again, an opportunity to look at creating that vision for our care management and looking at the gaps and knowing what do we need to do to put in place. And so that gave us an opportunity to kind of step back, look at where we were moving towards, and looking what we needed to do to really allow our cross-continuum vision to be created. Here we are now in chart phase 2, and that's really that vision that we did for chart phase 1 is allowing us that vision to be operationalized. I did want to take a moment to talk a little bit about our partners. We had to do a lot of work around building a scaffolding that really supported our post-acute relationships. So over the past year, the hospital had engaged in an RFP process to all members of our community collaborative. Our community collaborative is a meeting that we have that we meet monthly with all our local SNFs, rehab, DNA, all the care managers from the different partnering physician offices. We really look at ways in which we can improve care transitions. And so we had sent this RFP out. We were able to create a virtual preferred provider network with conditions of participation and memorandums of understanding that were executed for 11 skilled nursing facilities, an acute rehab, an LTAC, and then a visiting nurse hospice, which was chosen, which was Home Health DNA Merrimack Valley Hospice. The other big piece of that work was our partner through Elder Services of the Merrimack Valley, and they really had the local knowledge and the community needs and the expertise to manage complex patients, and they provided Coleman coaches that they had some experience through they had received some 3026 grant funding through the ACA a number of years ago, and really had created a care transition program around supporting patients as they transition. So we knew this was going to be a significant partner in the work that we were doing with CHART. And so that experience and really the work that we had been doing all along really helped us to look at causes of readmissions, and these organizations are very committed to change. I want to say that we in the Merrimack Valley we're pretty accustomed to change and looking at ways in which we can do that and really partnering together to achieve that change. We have a really strong network of community care providers, and we all understand the challenges that I've kind of described to you in this geographic region. So it's been a real strong collaboration for many years, and then the CHART program really helped us be able to really make that even a bigger collaboration. So I'm going to send this over to Terry now, and she's going to describe some of the work that we've done with data.
Our global aim of this project, again, as Aurelie mentioned, is to reduce unnecessary utilization of hospital and community health services, and we are engaging a community-wide health initiative and in our transitional care program, leveraging both technology and communication across the continuum. So our primary aim is to reduce 30-day readmissions for patients that are social complexity, medical complexity, or patients who have had a readmission within the prior 30 days. And we're reducing that by 20% over 2 years, which is a very aggressive goal. Our secondary aim is to reduce 30-day ED revisits for patients, same patient population with social and medical complexity by 20% over that 2-year period. So we initially started identifying our target population retrospectively. We were able to run reports that identified patients who were over 18 years old. We did exclude OB diagnosis. We excluded, obviously, patients who expired, patients who were transferred to another acute care hospital, and we excluded our waiver patients because we couldn't receive funding for, both patient populations. We did include patients who had a behavioral health diagnosis and that were identified as medically complex. So with chronic conditions such as pneumonia, AMI, coronary artery disease, COPD, diabetes, and congestive heart failure. But what we found identifying patients retrospectively is that we weren't really able to capture patients in real time, which is really what's desired. It was a delay in being able to identify the patient population and make the interventions as quickly as possible. So we changed our methodology, and I just want to reiterate something that Aurelie said is how important data and analytics is as a foundational element to being able to really execute this whole project. So having the analytic power to do this is very important. So we changed our methodology to identify patients in real time. So what that looks like is identifying a patient population, again, who is over 18, doesn't have an OB diagnosis, is not a Greater Lawrence patient with certain conditions, and is either inpatient or observation status. So that expanded our scope, not just including patients who were discharged. And then the case managers are able to identify those patients in real time and then begin the interventions earlier than waiting until the patients are discharged, and we get a report that's retrospective. So I think that was one of our most important learnings when we started this project, is being able to identify those patients in real time. And again, I have to thank our analytic team, Christian Delapiana, who has been really critical to being able to provide us with that information about those patients in real time who are eligible for this project. And I'll hand it over to Nicole, who will talk about the interventions and what we're actually doing.
Sure. So as Terry reviewed, we do have our goals for reducing 30-day readmissions and 30-day revisits to the emergency center by 20%. And we thought that we'd be able to do this by engaging hospital-based improvements, complex care management services, coordinating with the community providers, and as I mentioned, leveraging technology. So I know there's a bunch of items there that we wanted to tackle, but for the purposes of this, I really just wanted to highlight 4 of them. So we worked really closely with engaging the hospitalists, the emergency center physicians and clinicians, and also our community providers, and educating them on what chart was so that they could recognize patients as well. Because as we mentioned in the beginning, we were really working on retrospective data. So it was very much relying on the coding and the information that people could bring to us to be able to identify these patients. We also worked really closely to be able to develop our social workers and the chart team so that they could then provide 90-day care transitions or 90-day services to these patients post-discharge. And we also worked on developing individualized care plans, which I'll talk about next. And real-time screening and identification has been the biggest thing that we've tackled so far. So what we decided to do was review every single case that we presented to the hospital, either to the emergency center or was later readmitted to the hospital. And, the main goal of that in the beginning was to figure out why did the patient come back? Could we have implemented different services? Should we have done a different intervention? Kind of how can we improve on this? And then what we realized is that we were seeing the same names come back week after week after week. And so we decided to maybe shift the focus of how these meetings were going to go and really talk about those patients and what we could do to improve. And I think what's key about this meeting is that we have representation from the entire chart team, our partners at Elder Services. We also have a community physician who joins us, which has been invaluable. And then we also have representation from the SNFs through one of our employees who goes into all the SNFs and follows our patients as well. So it's really a great opportunity to be able to have a bunch of different perspectives at the table to discuss these patients. And we've had a lot of good dialogue, and what we're realizing now is that we can take this dialogue and these goals that we're creating and learning about what the community has to offer that we might not have known to be able to formalize really good care plans for these patients. And then since we started doing care plans, everybody wants a care plan. So what we had to do was create a committee to approve these care plans, and we have a full process so that once we develop these care plans, they're not developed in a silo. They have to be brought to this committee, which has an EC physician, an EC nurse, because a lot of times we know these patients are presenting through the emergency center. We have the social worker for the emergency center. We also have the chart team coming to present these. So it's a great opportunity for everybody to review it, determine whether the care plan is even realistic before we try to implement this. And ideally, we want the patients to know what we're care planning and what we want them to be their goals. It's not always possible, but I think it's a start where we are kind of developing them for them with the thought that they need to come to the table and help us participate in this. So since implementation in October, we've had probably 3 things that we really identified that we needed to improve on. The first was defining the target population, which Terry had touched on. The second was capturing at-risk patients through the risk assessment, and then the third being the interdisciplinary care plan meetings. So for the purposes of defining the target population, we have weekly operations meetings where we go over all the data, who we're seeing, and like we said, we wouldn't have been able to do this without Christian. He was really able to say, guys, you've got all these patients enrolled, but actually only 18 of them meet your target population. And so that was a huge wake-up call for us that we really needed to figure out a better way of doing this. And so what we had decided to do was really focus on the risk assessments and to be able to identify patients in real time. And so this is the second version of the risk assessment that we created. So the first risk assessment that we had implemented, we began it in December, deciding that this was going to be our way of targeting patients or identifying the target population. And even then, we realized that there was still a huge gap. So we had identified about 400 patients who would have qualified for the chart program via the risk assessment and actually had only enrolled 96 patients. And so we really were wondering, why is our target population so large but our enrolled population so small? So we decided to look at the patients that were coming through and why we weren't enrolling them. So what we noticed is that the risk assessment wasn't weighted, everybody was weighted the same. So you could come in, be 30 years old, smoke and speak Spanish, and you're at risk. And so we really looked at how do we make sure we're capturing patients who are truly at risk and not just capturing a wide net of patients. So what we decided to do was revamp our risk assessment. Specifically, instead of speaking Spanish, we wanted to identify patients with literacy or health literacy issues. So we removed that question and replaced it with the literacy question. We removed smoking. Ideally, what we wanted to do was identify the COPD patients who continue to smoke because we felt like those patients were at highest risk, but we realized that's not necessarily going to put somebody in the highest risk factor. So we removed smoking. And then what we did is we did remove live alone. So we modified the first question because originally it was patient needed assistance with ADL. Patient requires assistance with ADL. Patient lives alone. Patient requires assistance with medications, but what the chart team was realizing is that a lot of these patients, not all, but some of these patients had, they might need assistance with medications, but they have a daughter that provides all their medications for them. So we were identifying patients who needed something, but who already had the services in place to be successful when they went home. So we really wanted to identify those patients who needed assistance and didn't have the assistance. And so we implemented this probably 2 weeks ago, so we're really looking forward to seeing what the data for likely February will show, and if we can close the gap between the patients that were enrolling and the patients that were not enrolling. And then the last thing that we wanted to talk to you guys about was a case study, and I think I chose this case study because it brings everybody to the table. It's really what CHART is all about. So this is a 45-year-old male with a past medical history of COPD, oxygen dependent. He's got asthma, heart failure, diabetes, morbid obesity, chronic kidney disease. So if he walks into his PCP's office, even from the parking lot, he's sweating, he's short of breath, he looks like a patient you want sent to the emergency room. So what we really needed to do was work with the patient's PCP, because he had had a long-term relationship with one of his PCPs and then decided he was going to switch PCPs. So now you have someone taking care of him who doesn't know him at all, but we know him very well because, as you can see, he has presented to the emergency center 25 times in 2015, and he was admitted to the hospital 10 times. And generally, when he was admitted, he would be discharged to a skilled nursing facility. He's a very, very social gentleman, so he really likes to go to the SNF. I think he liked to present to the hospital because he got that interaction with people, and then he really enjoyed going to the post-acute so that he could continue those interactions. So what we really needed to do was kind of figure out a plan for this patient. So both the chart nurse and the chart social worker worked very closely with this patient and the patient's PCP and our post-acute provider to be able to kind of identify what's going on with this patient and what his goals are. And what we realized is that he wants to lose weight, he needs to lose weight, and he likes to be really social. So how can we help him meet his goals and keep him healthy and out of the hospital? So we took a interesting approach because we would send him to pulmonary rehab. The pulmonary rehab does not have nurses present, so they would see him, they would get extremely anxious, and they would call for him to be sent to the emergency center. So what we decided to do was get him hooked up with our outpatient cardiac rehab because there is a nurse present. So we went over, we met with them, we explained to them what he looks like at baseline, and so that when he did present, that he wasn't going to need to be sent to the emergency center, that this was his baseline. It also gave him an opportunity to have classes in weight management and to socialize with other people. So it kind of hit everything that he likes to do. And we were able to work with his primary care. We actually went to the appointment with him with his primary care so that we could get the PCP on the same page and who agreed to this treatment. So we've been very successful with that, and we really utilized everybody to be able to do that. So since he was enrolled in CHART, in the beginning while we were still trying to figure this out, he did have 3 emergency center visits and 1 readmission, but I can say since from October through July, he's had no readmissions, and he's only had 2 EC visits since we enrolled him. So that, to us, is a huge success. And so we definitely have many successes, but I think this one wouldn't have been effective without the help from, Elder Services of the Merrimack Valley, our post-acute facilities, the patient's primary care, and our own outpatient cardiac rehab center. So that's my favorite success story.
Great, thank you so much. I think we heard some pretty amazing things that are happening here at Lawrence General, as well as on the state level with the Health Policy Commission, really having this overall commitment to improving and for excellence. I heard a couple of really great themes throughout that community collaborative that Lawrence General runs. I'm actually going to say thank you so much to Lawrence General because you recently also had us as the QIO attending your meetings, and we've really gotten a lot out of that. And we heard a lot about data and analytics and how data really drives improvement, and I really just want to say that's really impressive that you were able to hone in on those data elements. We have time for discussion. The phone lines are open,
But I'm going to ask Morgan to give directions on how participants can unmute their lines to be able to ask questions.
Sure. If you have a question, you have to press pound 6 on your phone, and it will unmute your line and allow you to ask your question. Again, that is pound 6 to ask a question.
Thank you, Morgan. So while participants are in the process of unmuting their phones, we do have a couple of questions in chat, and please feel free to put more questions through the chat. We wanted to know how patients are identified through physician offices. I can ask the general team to maybe answer that one.
So patients, this is Robin Hines. So when patients are identified, it's through when they come into the emergency room. We have 24/7 ED case management down in the emergency room that applies that risk assessment that Nicole talked about on every patient that is going to be sent into a bed, so either observation or inpatient. And I also think that Nicole makes the case managers on the floor from a surgical services standpoint do a risk assessment as well, so that that then creates a flagging system for our social workers to create like a work list for them to look through all the patients that could be eligible to be enrolled into the CHART program. Correct, Nicole?
Right. We also run a report daily so that we can capture any patients who did not get a risk assessment when they were in the emergency center to make sure that they're getting one on the floor.
And we also do flag these patients within our system. So we have a pretty impressive care management system here. It's called Marcy, and what it allows us to do is create a flag that once the patient is enrolled into this 90-day program through the social workers and the care manager, if they do represent to the emergency room, an email alert goes out immediately to the EC case manager, as well as to some of our transformation physicians, as well as to the CHART team. So in real time, there can be real-time interventions for the CHART team to really help make sure that that patient gets the support services they need and perhaps prevent the patient from having to come back into the hospital. I see a question in chat, too, as sort of a follow-up to that. What about patients without a PCP who might be using the ED a little bit more as a primary care?
We make sure that patients leave the hospital with a PCP and a follow-up appointment. So we do have our own PCP practice with community medical associates, so we work closely with them to make sure that we are setting patients up with PCP appointments. Sometimes patients are registered as not having a PCP when truly they do have a PCP, they just haven't seen them in a long time, and then we also work very closely with the health center to parent patients through there.
I just want to make sure that you understand, too, that we really had to limit the population because we really only had a specific amount of funding. So we have, 2 social workers and a nurse and a community resource specialist. So we really had to look at ways that we could, change the way in which our case managers in-house did work, the way in which our social workers in-house did work, and how do we really partner with our community-based organizations to really support those services in that 90-day time frame. So patients that come into the emergency room that, may not necessarily have a primary care and overutilize the emergency room, the trigger is for these patients to be actually get a bed in-house for them to become eligible for the CHART program. Okay. That makes sense. Now, speaking of probably having to narrow your field a little bit due to the funding, there was a question about substance abuse in the chat. Do individuals with a substance abuse diagnosis, would they be eligible for this program?
Absolutely. That is one of the risk factors that they would score on. So generally what we've noticed is if that risk factor is checked, there's usually another risk factor that comes with that. So those patients would be eligible for the program.
Another question that came through chat was the group wanted you to speak a little bit more about the process of establishing relationships with partners and the protocols for communicating.
You mean with our skilled nursing facilities, so I guess the processes and the protocols are different for each community-based organization. In terms of our skilled nursing facilities and what happens if patients get discharged to SNF or to rehab or whatnot, we actually have a care manager that follows those patients. That's not funded through the CHART program, but that is something that we felt was necessary to really help assist to manage our high-risk patients as well as our financial at-risk patients, because we also belong to an accountable care organization. We also have bundled payments. So as you can imagine, we're trying to sort of manage a lot of different populations. But we do have a care manager that follows CHART patients as well into the skilled nursing facilities. And so he's able to really work with the social services departments at these facilities to really ensure that they know that this patient has that extra support services once they leave the skilled nursing. Because remember, this is the 90-day program that we follow them. And Nicole, do you want to talk a little bit about the relationship with our community-based organization through ESMD and how we use the transition coaches?
Sure. So we utilize the transition coaches in a variety of different ways, and I think that we're still kind of looking at how we can increase that relationship as well. Basically, the transition coaches will follow up with the patient via phone call, and they'll also do home visits, which has been really a great experience, because a lot of times, you know, when you call a patient, oh, I have all my food in the kitchen, I know exactly what to eat for my diabetes, and then you go, and what we've seen is that there's just a hot plate and canned vegetables and sugary cereal. So it's been really eye-opening to have their perspective from in the home to be able to share with us. They come to our operations meetings. They're present at our interdisciplinary case review meeting, and they bring a lot to the table for us to be able to effectively care for these patients.
Thank you. I'm going to switch to the phone now and to see if we have anyone on the phone with a question. Okay.
Great. Well, while we wait for that, Cheryl, we do have a question about the PCPs and establishing relationships with them and the process for linking them into the process. Can you talk a little bit about that?
Sure. So when a patient decides to be enrolled into the program, we send each patient's PCP a letter to let them know. So the patients sign a very extensive consent that gives us permission to speak with all of these post-acute providers, including the PCP. And so what we do is once the patient is enrolled, we let the PCP know by sending them this letter. It's a very generic letter that lets them know about the CHART program, how long the patient is going to be enrolled for, and that if they have any questions, they're welcome to reach out to us, because we can't do this without their assistance. We have had some patients who don't want to sign up to the program because they don't want us communicating with their PCP, which has been very interesting. But all in all, I think that we've done a good job. We've also gone to different meetings with different PCPs to explain the service to them.
We can tell from some of the chat questions that people are thinking, how can they operationalize this within their settings? We've had a couple of very specific questions. One is, does your ED support Section 35 of chronic users? And what is the policy of your ED in dispensing narcotics?
Sure. So we have in the past sectioned a lot of patients who we do identify as at-risk and frequent flyers for substance abuse. So we do work closely with our physicians in the court to be able to do that for these patients. We are also working closely with PCPs to let them assist in this process as well. As far as the policy for dispensing narcotics, I think part of the care planning is
our ED physicians have agreed to some new Mass Hospital Association guidelines related to limiting prescriptions for opioids and doing a thorough assessment and also looking at the database to see where else the patients may be getting prescriptions. Our EDs have all agreed to do that and believe that's really an important part of the care that they provide is being very aware of the overuse of opioids and overprescribing. So I have to say they've been, really embraced those new guidelines from the Mass Hospital Association.
Right. In addition, another specific question that came up in chat that might help you or help our participants operationalize this in their settings is, can you identify what your case managers or identified patients ratio have been throughout the process of this program?
So I think we have about a little over 100 enrolled patients right now. So like we said, there's 2 social workers and a nurse, and so they probably each, it's hard to narrow it down by exactly how many each one of them holds, because a lot of times they're all helping each other with these cases. Some of them own one patient because they've built a relationship, but others share, especially between the nurse, because, what we realize is that social workers are very good at doing the social determinants of health assessments and providing those assistance, and nurses are very good at providing the medical assistance. And so a lot of these patients, because they're both dually complex, need a little bit of both. And it really depends on the patient's needs. There's some that are extremely high risk that they're on the phone with maybe daily, and then there's others who their interventions are much smaller.
We've had a few questions about the risk assessment. We had a question, a request to share it, and then the second was, is that scored? Wondering if you could talk a little bit about that.
Sure. So we'd be happy to share the risk assessment with everyone, and the risk assessment is scored. So the first question, does the patient have any of the following risk factors? That any of those boxes will score a 1. And then any of the answers, if the answers are yes, they all score 1. Yes. So if you answer yes to any of the questions, you would score 1. So for us, we identify that any patient who scores 2 or more, we consider them at risk, and those are the patients that would be in our target population.
Excellent. And we also had some interest in your physician involvement in the CHART program, if there's a physician champion or if it's really working with the PCPs. Can you talk a little bit about that?
So it's really a case-by-case situation. We do have what we call transformation physicians here at the hospital that's led by our Chief Transformation Officer and Vice President of Population Health, Dr. Emranand. And he really is our sort of care transition expert in-house. But we have those physicians sort of available as we need them to get involved with certain situations, whether it's whether a primary care is having trouble understanding that we really need to get in touch with them and that we really need to formulate a plan with them. That's a big piece that we utilize them for. As Nicole described, we do have this very great relationship with Elder Services of the Merrimack Valley, and they have a medical director, Dr. Shriver, who attends all the care planning meetings, as well as you described too, the ED physicians that are actively engaged in the care planning meetings as well. I don't know if you have anything to add.
I mean, I can't say enough about Dr. Shriver. I think that having him there is just a perspective that we've never really had before, because we are within the walls of the hospital, and he brings a much different perspective. So in a way, we look at him as kind of the voice of all the PCPs out there. So it's been very, very helpful.
That's excellent. We have some questions about technology and data sharing. Do you use an HIE or to send and receive information from PCP and or
So part of the actually RFP through CHART was to enable technology and really work with engaging an HIE platform in order to send information. Initially it was to really engage with the Mass Highway, but what we found, and I think many of the CHART participants found throughout the pre-planning phase, was that there's a lot of regulations around use of the Massachusetts Highway. And so we actually have our own HIE right now through Relay Health. So we're able to send CCD documents. These documents aren't always in the right format that physicians always want to have. We're looking at a whole assessment of our HIE system right now. But we do send continuity of care documents to I think 3 different skilled nursing facilities, 1 acute rehab, Northeast Rehab. I think Genesis skilled nursing facility, there's 4 of them, so they receive all our CCD documents in that form. Home Health DNA receives that as well as Elder Services now, the Merrimack Valley. It's not a direct-to-direct, though. It's an inbox-to-inbox, so it requires somebody to have to go and pull the information out and then parse it out. So as we continue to work with HPC and really work to enable technology in a different way to really make it more meaningful, that really is a goal of ours to look at how HIE is going to help support that.
Excellent. And I think that right now that underscores the importance of the communication and the relationships that you've established.
Yeah, I mean, it really is sometimes a case-by-case basis where we have to really pick up the phone and call one another. I mean, and sometimes the real-time communication is the best communication you can have, right? It sounds like we have somebody on the phone. Do you have a question?
Yes. My name is Jonathan, and I was just listening to the major components listed in your program there, and I just wanted to see if I got most of them. Or all of them. Basically, they have a permission letter, you have a risk scoring, you have transition coaches, communication with community services, then you have pagers when they hit the ED, and then, of course, you have your care plans that get disseminated and whatnot and utilized. Am I missing anything additional? Actually, the transitional care doc to consult with as well.
And really, I can't specify enough how important it is to have a social work and nurse team because it's such different disciplines that it really brings, a different perspective, wouldn't you say? Absolutely.
And the importance of data and analytics to help you, one, identify the patients, and two, kind of track your improvements and whether you're making a difference.
Okay. Thank you.
I'm wondering if you could talk a little bit about the role of building the program and engaging patients and families. I don't know if we've talked about that.
Sure. So when the patients are identified as being at risk via the risk assessment, the social workers go down and meet with the patient, and they let them know what the program has to offer. And we definitely struggled with this in the beginning because it was hard to kind of describe what the program was without scaring people away. But I think what we've been able to do is really build relationships with patients before they leave the hospital so that when they leave the hospital, it's the same person that's calling them, the person that trusted them when they were here, that helped them kind of set them up with initial services when they were here. And I think that has gone a long way. We also, with the transition coaches, they also help to build that relationship with having a consistent person going into the home and seeing the patient. We have some patients that don't want to see anybody other than the person who walked in the door the first time, and they come to the table and they're able to make different situations so that they're able to do that. And I think we've been able to build a really good relationship. When we had a patient who was really, really frustrated one day in a pharmacy, and he picked up the phone, and who did he call? His social worker. And it's great. And a lot of times what we've noticed, too, is that patients come in with nothing but their social worker's card in their pocket. And I think that that's a huge, huge thing, too.
That's fantastic. I think we have time for one more question, and the question really was about the use of technology. We talked about the importance of data to drive improvement. But the use of technology to identify and target this population. Can you speak a little bit about that?
The use of technology. I mean, from an analytics point of view, again, emphasizing that we went from retrospective identification of patients to a real-time identification of patients, and as Nicole just mentioned, being able to identify those patients as soon as they come into the emergency department, that's when we start our work, and develop that relationship with the patient so that by the time they're discharged, they have a plan, they have that relationship, the beginnings of that established. So moving from retrospective to real-time identification, I think was probably one of the most important improvements that we've made, in addition to, tweaking the risk assessment and, the wraparound services in the program, but backing up into real-time the identification of those patients.
And from a technology standpoint, it really does help to have a tool to manage these patients, a tool that connects both your inpatient side with your continuum side, as well as what your skilled nursing side is, or your post-acute side. So I think that's a huge piece of that technology that just can't be underestimated.
So, and one additional, the Morrissey tool has been a really important benefit for us in this project. Where through our data and analytics team, we've been able to actually build in fields in the Morrissey tool to capture what are the interventions that are being made for those patients, so that over time we'll be able to see which interventions are having the biggest impact. We don't have that information yet, but building those fields into Morrissey and capturing them in real time with the social workers and nurses who are working with the patients, I think will be very fruitful. We're, anxious to see what that impact is.
Well, you've all done some amazing work, and we're very grateful that you shared that with us today. I know there are a few additional questions in the chat that we didn't get to from the New England QIN-QIO side. We will obviously review all the questions, share it back with the team of presenters, and then make sure that we share that back with the field. I'm going to hand it back to Cheryl to wrap up the session.
Great. Thank you so much, Lynn. I just want to thank everyone for a really robust discussion. I think when we walk away from a meeting like this and a discussion like this, I think we feel excited and ready to try and start something new and implement some change to improve our performance overall. This final slide gives you the lead, the care transition state lead contact information for your state. Please reach out to your state lead if you want to learn more about what's happening in your local area for care transitions. As one of the state leads here in Massachusetts, we're very happy when we hear from providers, and we'd like to be able to make these connections for you to different programs and approaches that are happening across the state. Thank you very much to our presenters for the great information that they shared and for their willingness to really be open and have this discussion with us. After this session, participants will be asked to complete an evaluation. Please know that your feedback is very important to us, and we really do take that very seriously. I want to thank you again for listening in, and I wish everyone a great day. Thank you.
The reader has disconnected. The conference will be terminated in 5 minutes.